Understanding the architecture and blood supply of the face is critical to avoid unwanted complications. By standard definition, the facial artery ascends above the mandible deep to the platysma and the depressor anguli oris. It will branch into an inferior labial artery and a superior labial artery. Continue past the corner of the mouth toward the nose as the angular artery. The angular artery will eventually terminate at the medial commissure, joining the dorsal nasal branch of the ophthalmic artery. Beginning in the neck, the facial artery will give off a submental branch. At the jawline, the facial artery is 2.3 millimeters in size. The inferior labial artery origin is approximately 2.4 centimeters from the lateral commissure and 2.4 centimeters from the nebular border, with a diameter size of 1.3 millimeters. The artery will course submucosal to the level of the labial-mental crease. At the labial-mental crease, the artery is 2.3 millimeters in depth. The artery will give off perpendicular perforators to the vermilion. In a small percentage of population, there is an artery variant where a common branch of the superior and inferior labial arteries exist. In that case, the inferior labial artery will course along the vermilion border. The superior labial artery is within a 1.5 centimeter squared area near the commissure at a depth of 3.5 millimeters. A recent study suggests you can use your thumbnail to approximate this area. In 22% of patients, the superior labial artery will give off alar branches. The artery will maintain a depth of 3 millimeters, and at the medial 1/3, the artery will descend caudal to the white roll. In 85% of patients, the artery will give off septal branches, and in 1/4 of those patients, the septal branch will actually course superficial to the muscle. In over 90% of patients, the nasolabial fold and facial artery have an intimate relationship. The artery begins 1.7 millimeters medial to the fold and will cross the fold at the superior 1/3 at a depth of 0.5 millimeters. The angular artery will traverse laterally to approximately 3 centimeters lateral to the ala. Studies have shown a detoured course of the angular artery in 30% of patients. The artery will traverse along the inferior border of the orbicularis oculi muscle and up towards the palpebral fissure. A good marking is a midpupillary vertical line level with the supratip break. It's important to note that branches emerge in the subcutaneous layer at this level from both the angular artery as well as the palpebral branch of the infraorbital artery seen here. The palpebral branch will ascend level with a line from the medial corneal limbus. So caution should be exercised when performing injections along the tear trough and the nasojugal groove. As we progress laterally, we identify the zygomatical facial artery, which comes from the ophthalmic system. It exits approximately 1 centimeter from the infraorbital rim and 1 centimeter lateral to the lateral canthus. The superficial temporal artery will give off the transverse facial artery. This artery will start at the lobule and then ascend to then take a horizontal course level with the tragus along the masseter. This artery is probably not as important in injections because the majority of injections occur in the anterior mobile face. Laterally, this mass is fused. Anteriorly, this mass is mobile. As we progress cephalic, here we identify Patengi's line and the temporal ligamentous adhesion. The superficial temporal artery will give off an anterior frontal branch that has an intimate relationship with the frontal branch of the facial nerve. Injections in this area can cause bleeding and potentially neuropraxia, so caution must be exercised during temporal volumization in this area.